Hello everyone, good evening. Greeting from the land of Bhagwan Birsa Munda and coal capital of India, Dhanbad. Myself, Dr. Apurv Kumar Datta from Sexual Medicine Committee, welcome you all in the fourth series of Confusion to Consciousness series, a webinar series. Now, today we have very special topic and very special guest with us. The topic is the premature ejaculation. So my dear friends, before we start getting our blessings from the seniors, first I would like to start the Foxy theme video.
Dear friends, Foxians and women of my country, I am Dr. Shanta Kumari, President of the Federation of Obstetrics and Gynecological Societies of India. As a little girl, I told myself that I have to become something to make a difference. I always believed that if I desired something wholeheartedly, there is a positive force which makes it happen. And here I am, friends, standing in front of you as the 60th President of Foxy, the 38,000 strong committed body of OB-GYNs taking care of women's health in our country. As a young girl, I realized that women play a key role in this world, just like Mother Nature or Stree Shakti as we revere it. It is a guiding force behind all forms of God's creation. And it's only a woman who can actually create a new life.
Hi, I'm Kareena Kapoor Khan and I'm so happy to be here with you, if only on video. Pregnancy is a beautiful experience and I have loved having my babies. I congratulate Dr. Shanta Kumari as taking over the 60th president of this eminent organization.
Stree Shakti is the embodiment of 5 elements: the sky, the air, the water, the earth, and the fire. Any imbalance in any of these 5 elements creates chaos and calamities. Similarly, when a woman's health is neglected, it disrupts the universal equilibrium. The intimate link between environment and human well-being is very well known. With increasing awareness of the need for clean water, pollution-free air, and pesticide-free food.
Hi, I'm PV Sindhu. Well, it's such a beautiful feeling for me to be an empowered girl, to be a girl in a nurtured and a safe environment.
Protecting health by preserving nature and its ecosystem is easier than curing any disease. So we have taken up the concept of minimizing the female morbidity and mortality and fetal effects by mitigating the adverse impact of environment. My theme this year goes beyond Foxy's commitment towards women's healthcare. Foxy for all, always.
Foxy for All is another inspiring campaign. What you do in this organization impacts the lives of all of us women in India.
And Dhira to stop violence against women. Foxy for all, always will strive to make the girl a Sahasi with Swachhata, Samruddhi and Swasthya. To be Surakshit with Shakti to reach her full potential as a woman.
Dr. Shanta Kumari with the theme Foxy for All Always and Dhira Stop Violence Against Women will empower many girls. I firmly believe that only a safe girl, Surakshit Kanya, can grow into a healthy woman, Swasth Mahila.
Violence against women. I think it's a silent pandemic and I'm so happy to be a part of this campaign.
If any woman has a problem, where does she go to? Not to the police or court or the lawyers. She goes to her friendly OB-GYN, who is her first point of contact for help. So I have started Dhira, an initiative close to my heart, to sensitize our OB-GYNs, the police, the public, and to partner with men to say no to violence against women.
I completely support her vision and mission as President Foxy and also especially support her campaign, Dhira Stop Violence Against Women.
A healthy environment is the core of a woman's health. A healthy woman makes a family happy and a strong nation. I, as the president of Foxy, declare my commitment towards women's health and safety.
So, once again, I welcome you all after this very inspiring video. I would like to invite none other than but the most amazing person, the person behind organizing this whole program. He is instrumenting behind all the programs of Sexual Medicine Committee and bring out such a important and old topic to be discussed in such a great platform. None other than but our own chairperson, Dr. Neeraj Jadhav, sir. We all know sir is at present the chairperson of Sexual Medicine Committee, and at present he is the vice president of the Menopausal Society of Rajkot. So welcome and over to you, sir, for your kind word.
Thank you, Apurva. Welcome and good evening to today's webinar. This is our fourth session of this series, that is Confusion to Concession. Why we started this series? We previously did the masterclass series, which has a total 6 sessions. So after finishing masterclass, we thought sometimes what happens, we know so many things about the subject, but when a patient comes, we become confused. We have so many options to choose from, and it's a really confusing situation. What will be the best possible management for this patient? So to clear that confusion, we started this series, Confusion to Concessions. And here we don't have any theoretical aspect. We only discuss the practical situation and only discuss the clinical scenario. So today it is a premature ejaculation. We will discuss about that. We all know that premature ejaculation occurs when a man ejaculates sooner during sexual intercourse than he or his partner would like. Premature ejaculation is a common sexual complaint. Estimates vary, but as many as 1 out of 3 men says that they experience this problem at some point of time. Exact definition of premature ejaculation includes distress as an important dimension. However, the word distress has a negative social implication, and its existence is denied by most of the men with a PE. So this dimension of PE is better captured by the word bother. The extent of the bother defines the severity of PE. One study reported that 64% of the men with the PE rated their extent of personal distress as quite a bit or extremely compared to the 4% in the group of normal control. So let's get our confusion clear about this subject, that is a premature ejaculation. And we have two very efficient moderators with us to present the case scenario, and we have very eminent speaker with us today who will answer and solve our confusion and make everything crystal clear how to manage such type of cases. So thank you and welcome you all for this today's webinar on premature ejaculation. Over to you, Apurva.
Thank you so much, Neeraj sir, for the kind words. As we know, whenever we started some program, first we have to take blessings from our seniors. And today is really a very special day with us because today we have a very special 2 guests with us. First, who I consider as an encyclopedia himself, then but Pankaj Desai sir. Sir himself is definitely, you ask anything to sir and he is with all ready with the answer. Sir, you are teachers of the teachers. Thank you so much for always there, for always, whenever we called, you are always there for your blessings, for your advice, for your guide. You didn't need any introduction. Sir is the past president, Foxy and whatnot. Sir, over to you for your kind words and blessings. And we are all, eager to listen some stories, some songs from you, sir. Thank you so much, sir. Over to you, Pankaj, sir.
Honorable Dr. Jadhav, the chairperson of this committee, who has metamorphosed this committee. This committee has only 2 fates, all or none. Out of out of so many ideas, if somebody sits in this committee with some cobwebs, the committee for those 3 years will go in hibernation. But if somebody sits with an aim, with a mission to spread accurate information regarding something which is so much necessary, then this is the result. And I am seeing, and I also read the reports which come from Foxy, wonderful work being done by Neeraj, and I congratulate you. And I have always seen, right from the days when I was rising is not the right word, when I was slowly metamorphosing into Foxy, that the committees are the bulk of work of Foxy. The entire biggest body which generates work of Foxy are the committees. Rest all cannot match this work. And people like Neeraj, they add voluminously to the activities generated by Foxy, and that too on a scientific basis. My co-chairperson, Dr. Kavita, is not a slave of any appreciation. She is a great lady, a dynamo, and these are the people from whom the society genuinely benefits. They touch lives, and I am fortunate that she is here. Usually, I know the speaker, Sunil Jindal, the chair, Sunil Jindal, Rahul Reddy, all of them, wonderful. And Apurva is holding a good fort. Apurva, committees are actually for grooming people not to become the subsequent office bearers. You will be, but the committees evolve you into leaders. They are different things. And you are working hard, and I am seeing a great leader of benefit to the society here. I am not finishing here. I am going to take 5 minutes more. And usually I don't give routine sort of lecture. And I love to tell story, though I am not yet a grandfather. Kavita is a grandmother, so she knows how beautiful it is to tell stories. I'll tell you a story today. I remember as a resident doctor doing post-graduation, when I was doing post-graduation, there was a senior consultant of ours who always had her anger on the tip of her nose. Name is not important. We all used to be terrified about her. Once, when I was a junior most resident, while I was doing some post-operative routine work in the wards, I heard a big commotion near the operation theatre door. The operation theatre was near the ward. She was shouting at the top of her voice. Inquisitively, I went closer to find an old man standing in front of her, trembling with folded hands, as if pleading for mercy. She was blasting him. It seems she came out of the operation theatre after some difficult surgery and saw something unpleasant. There were BD stubs. BD, you know, I know that in India it is not a new word, but they are stubs of desi cigarettes all around, plump near the operation theatre door. I did not need a minute more to understand what must have happened. The man who was being blasted must be smoking those BDs, and I must have thrown the stubs around. The lady must have seen the litter, and the flare followed. She didn't leave the old man, who was now actually weeping, collect all the BD stubs and throw them in the dustbin. Tidiness restored, all well, the lady left with a gleam of victory in her eyes. The story doesn't end here. In fact, the story starts here. We had nearly forgotten this episode when in the evening, after all had left and our teaching sessions were over, I as a junior resident went back to the post-operative ward to complete whatever was remaining. There in the ward, I saw the old man sitting, or rather squatting on the floor, near one young woman patient who was seemingly operated. He was holding her hand as the patient may move the hand and dislocate the needle of running or the running saline drip. He had a totally indifferent face. He was looking out of the window, staring absolutely vacantly in the dark sky. I quickly pulled a stool for him so that he could sit a little more comfortably. He looked up at me as he sat on the stool. He just sighed. He spoke nothing. I tell stories in all inaugurations. They are all different stories, but they are all true stories. I asked him, "Have you eaten something?" He didn't reply. Wasn't the answer obvious? I asked myself. Tea and biscuits were arranged, but he seemed to be too scared to take it. He was so clearly hungry. I sensed the fear that was doing rounds in him again of the morning. The same face suddenly came up. His silence spoke loudly, while he did not utter a single word. He was too afraid to eat in the hospital. He was blasted for smoking. Now he cannot eat in the hospital. And also he was too frightened to leave the hand of the patient, as he was strictly instructed not to move. हिलना नहीं, वो सुई निकल जाएगी. Having reassured him, I arranged a peaceful corner for him outside the ward, giving him some privacy, and then got on to my work. After about half an hour, so deeply engrossed in my work, I felt someone staring at me. You can make out somebody is looking at you, and that is awareness. Without even actually seeing them, you can make out somebody is looking at you. I looked up to find that same old man. He was peering at me from the window. As I looked up, he smiled gently. And in the Indian tradition, he just folded his hands and said namaskar, posing as if to say, "Thank you, Babu," and went back to the patient. I left him in his space. After a couple of days, I could see the man in the hospital compounds, now visibly relaxed, but still very silent, sitting in the corner waiting for the gates of the hospital to open and the visiting hours to begin. I walked up to him and just placed my hand on his shoulders and asked, "How is your patient?" He replied, of course in Gujarati, "She is much better now." "Who is she?" I asked. "Sir, she is my only child." "Sir, she had torn her uterus." He could not say rupture uterus. He said he had torn her uterus. Uska bachchadani phat gaya tha. We were tossed from primary health center to the referral hospital, and from there here. She was operated here and she is saved now, sir. The entire picture was now clear to me. This man's only child, his daughter, was on the deathbed that day. She was getting operated. He was facing a real possibility that what would come out from the operation theater would not be his daughter, but her dead body. He must be in unimaginable, indescribable pain and stress. In that stress, he must have smoked bidis after bidis. Little did this simple man realize that he was in a hospital and therefore not supposed to smoke and make the place dirty. Did it matter? Do such rules matter at that time? No, they don't. He smoked away in sheer agony at the prospect of losing his only child. We, the doctors, on emerging from the operation theater, did not even care to tell him as to what has happened. Instead, we blasted him for the dead stubs which were near the operation theater. He had smoked in the hospital. I have never forgotten this incident in my life. I know that as doctors, when we operate on a patient, we are not operating on one human being, but we are operating on the entire family which is waiting outside. The agony is the patient is anesthetized, so he or she doesn't feel the pain. But the family is not under anesthesia and is undergoing the mental surgery in all consciousness and pain. Lest we forget. Thank you, Neeraj, for inviting me. God bless you.
Thank you.
Wow, sir.
Beautiful.
Wow, it's an inspirational story. And in that simple story, you have अपने लाइफ के हर पार्ट को छुआ कि डिसिप्लिन क्या है और डिसिप्लिन discipline nahi hota hai, sir. It's wonderful. Thank you so much, sir, for coming, for blessing, and for always giving us the inspiration. Second, the guest of honor is again one of my favorite, and ma'am smile is like क्या हम बोले what Pankaj sir has already कि भाई अगर वो जब मुस्कुराती हैं तो सारा सब कुछ अंधेरा हो जाता है और मैम ही दिखती हैं. So ma'am is very well known to all of us. Ma'am is the vice president Foxy, and AICOG, she is the organizing secretary of that. And thank you so much, ma'am, for always helping us, for always being with us, for always guiding us, and for giving your precious at this moment. जब भाई एक महीने के बाद आपका AICOG है, and we must know how busy you are, but you still come here and giving us the time. is really thank you.
ज़्यादा हो रहा है.
No, ma'am, over to you, ma'am. Over to you for your blessing.
Thank you so much, Arup, for all the lovely introduction. First of all, I thank Dr. Neeraj. आज तूने मेरा दिन बना दिया, that making me to sit in close to Dr. Pankaj Desai as a guest of honor. Really, मैं इतना deserve करती नहीं हूँ, and मेरा इतना status भी नहीं है. But I think being a Foxy Vice President, I think you made me this. You have given me the chance to sit close to him. Really, it's really I'm feeling proud for it, and thank you so much to you. And the most important part is like 22 years back, he was the fun of the person who told me कि आ सकते हो, you also can come in the Foxy, but you should have some good backup plans, some anything. And thank you, sir, being a mentor and a very good teacher, very good friend. और I cannot say I don't have words. What a story you tell, मैं उसके ऊपर कोई narration कर नहीं सकती, मेरा इतना standard नहीं है. But I think you are जब सब बोलते हैं teachers of teachers, मेरे को लगता है you are friend of friends. You are also, I don't want to describe much more, sir. Just love you, sir. That's what I can say. And Neeraj, so nice of you to have Arup and especially the Sunil Jindal sir over there, nice person, and Rahul Reddy as a speaker over there. So thank you so much. And the topic is excellent, consensus to confusion. All the whole life I have so much confusion to have a consensus on many subjects कि ये करें या नहीं करें. And your subject is this sexual medicine. I tell you, in this country, not in the patients, but into the doctors, there is a great social taboo about the sexual description or many more things. And your topic today is excellent, premature ejaculation. I think it's a need of time, and your lectures and everything will be very helpful to the society. So Neeraj, all the best. Keep good work. And I'm so proud of you as a friend of yours, and you are doing a good job in a subject where everyone likes to join. And Arup, all the best for you. Thank you so much. Once again, Pankaj sir, thank you so much. Thank you so much.
Thank you.
Thank you so much.
With the blessings, with such a inspirational words from our seniors, now it's the time to start our scientific session. Again, for this session, we have a great faculty and speakers, and really one of my favorite, Rahul sir. It's always great to talk to you, to see you, your smile. Wow, that killer smile. Thank you so much, sir. Sir is andrologist, sexologist from Hyderabad. So welcome, sir, and thank you so much for accept our invitation. And so I think, and last but not the least, my friend, my mentor, my senior, Sunil sir. Sir, हम तो आपके आवाज के दीवाने हैं. Thank you so much, sir. Let's start our scientific session. So it's a case-based study. In the first season, what we have, it was just a interactive, and it was like a slide presentation. This is a new type of format where we share with you the live cases, and we discuss those live cases, how to deal with that. So let me share the slides, and we will take up the questions one by one.
Shall I?
Sir, it is visible?
Yeah, it's visible.
Okay. Sir, Sunil sir, can you just start with?
Yeah, can I share the slides? Can I share the slides? I'll be very comfortable after one case to carry on, please. Huh?
Okay. Yes, sir. Yes, sir. Please. Sure, sir.
So first of all, Thank you everybody for being here. All the people who are here who have joined us. If it were not for you, you could be doing anything else, but you decided to be here for the sexual medicine program, which is great. Just a minute, please. Just a minute. Yeah. So I think now, do we have a single slide? Do we have a slide share? Hello?
Sir, you can. Yeah. Yes, sir.
So Dr. Rahul Reddy is a very close friend, Dr. Apurva, Dr. Neeraj, who actually have come up with this beautiful program. And it's a case-based whole story. So the first thing which I'd like to ask you, Dr. Rahul, is what is the definition of premature ejaculation? And in this definition, which words are most pertinent for the definition?
So definition wise, there are various definitions from different societies. But for common man point of view, one single thing, if a man is ejaculating within 2 to 3 minutes, this 2 to 3 minutes is intravaginal latency time. So this is after penetration. If he is ejaculating in less than 3 minutes time, then it is called premature ejaculation. So this is simple definition so that everybody can understand.
Yeah, but if we try to understand, some beautiful thing is there is no fixed timing per se. It occurs probably less than 1 minute for a lifelong, and probably less than 3 minutes for an acquired. So what means to say is there is no hard fixed rule. This is the beauty of the definition. And also something which I have always felt about this definition is, this is vaginal penetration. If you ask me, they have not taken into consideration in sexual medicine in this definition that people could be having sex otherwise too. So not only vaginal penetration, probably if they're having sex in any other fashion, even then the latency time should be as it has been mentioned. Dr. Rahul, now what could be the causes of premature ejaculation?
There are different causes. See, actually, clinically, I divide them into 4 different areas. One is psychological. In psychological, either anxiety or excitement, these things comes under performance anxiety, they come under psychological cause. Second is hormonal cause. Third one is local causes. Local causes in the sense penile, sometimes phimosis, tight frenulum, sensitive glands. These come under local causes. And third one is neurological. Fourth one is neurological. Neurological cause can be in the brain, or it can be in the prostate. Because of the prostate, there can be disturbance in the ejaculatory reflex mechanism. So generally, I divide them into these 4 categories. Psychological, hormonal, local causes, and neurological.
Now, out of these, which is the most common cause which you have seen in your practice?
Most common cause is psychological.
You mean it for acquired, or do you mean it for lifelong?
Even for it's for acquired. Even for lifelong, basically most of them, they try to masturbate very fast, very quickly, and they get used to that. And once they get used to that, then actually we have to count them as a psychological cause. So only one variation, very few members, they have lifelong premature ejaculation. That is a different story. But most of the people, in at least 70% of these people, it is psychological.
Okay. Now, is there any genetic basis for premature ejaculation?
Yeah, definitely. Some, at least 3 to 4% of people, they have a genetic trait.
Now, this is the first case. The first case which we have is a 24-year-old unmarried male. So he's not been married. And he comes over and says to the clinic, and he says, I just discharged very fast. Now, in a condition like this, what are you going to ask him? the questions which you normally will ask him?
So this is a very common scenario because most of the males, whether they have a partner, whether they are masturbating, whether this premature ejaculation is with masturbation or during intercourse, we have to ask. And most of the people, they don't have sexual experience. They just the timing, they actually confuse with all these porn videos. Most of the, at least 70% of the people, unmarried males, they see porn videos. They think that they have to ejaculate in 30 minutes or 40 minutes, and they confuse. When they start ejaculating in 3-4 minutes, they think this is as premature ejaculation.
Okay, so now this patient has no ED, he has no urinary tract symptoms, he does not have, painful ejaculation, he doesn't have any post-ejaculatory pain. Now, how are you going to treat him?
So now, sir, in these patients, generally, first thing is local examination is very important. And I always ask them in the history, during the ejaculation, if he ejaculates, if it is during masturbation, I ask them whether every time he masturbates, he is ejaculating faster, or sometimes he is ejaculating slower and he's taking time, and sometimes he is ejaculating quickly. That is important. And how he is getting excited is important. Sometimes most of them, when they see porn videos during masturbation, they tend to ejaculate quickly. And people who masturbate once in a month, once in 15 days, that means after long gap, they tend to ejaculate quickly. So that is what important, that we have to. If he says, doctor, only first time I'm just ejaculating normally, second time I'm taking time, that means it's a simple psychological issue. So we don't have to treat them. So if they say even during second act of intercourse on the same day, if he's ejaculating quickly, then we have to take it seriously. So first thing I do is I will examine him. I will check for local examination, penile examination, whether there is any sensitivity of the glands, whether there is any phimosis. That is what we have to check. Then if there is no local cause, then I check for hormones.
Now, what are the hormones which you're going to get checked for him?
I do thyroid profile, testosterone, and prolactin.
Okay.
These three hormones.
Three hormones. How is thyroid associated with PE?
It's not hypothyroidism. Hyperthyroidism can cause PE.
Can cause PE, right? And in case the prolactin
hyperthyroidism, most of these people they will have anxieties. Then it is again anxiety related premature.
And with prolactin, what happens in these males?
Prolactin is known to cause ejaculatory dysfunction. But some patients, they have delayed ejaculation. Some patients, they'll have premature ejaculation. Actually, we don't know how it affects. But in most of the patients, why it is causing, some patients with hyperprolactinemia, they will have both issues. Either delayed ejaculation or premature ejaculation. But prolactin, I think it disturbs neurotransmitters.
Okay. What about testosterone per se? What is the role of testosterone?
No, testosterone, why I do testosterone is it may not be directly related to premature ejaculation, but people with testosterone deficiency, they can have low libido, sometimes erectile dysfunction. And because of the erectile dysfunction, secondary to erectile dysfunction, they can have premature ejaculation. Just
fantastic.
To rule out. Yeah.
Fantastic. So, Dr. Rahul, you so simply, so clearly have clarified the role of hormones, why you get them done, and you get them done for the purpose to understand if there is there. Now, the interesting thing in this patient is that in this patient, he has both during masturbation and intercourse, his hormonal profile is normal. How will you treat him?
So if it is normal, so now we have first thing what we have to see is whether he has a regular partner or not. And particularly in premature ejaculation, before starting our medication, it is very important to ask whether they have a regular partner or occasional partner. If he says I'm having intercourse once in 15 days or once in 2 weeks, 3 weeks, then I prefer on-demand therapy till he gets married. Once he is married or once he has a regular partner, then I put them on daily doses. So now we have daily doses means we have only 3 drugs, SSRIs, either fluoxetine or paroxetine or depoxetine. And based on in these 3 drugs, fluoxetine and paroxetine are for daily dosages, and depoxetine is a on-demand drug. So now before starting them again, as you said, we have to give them proper counseling. We have to tell them this is treatable, because most of these unmarried males, they confuse with erectile dysfunction, and they always compare their performance with porn videos. So most of them will have suicidal tendencies, and most of them, they avoid marriage only because of premature.
Absolutely. Absolutely. The clinic is full of people who come to you and say कि जी सुसाइड करने जा रहा था, बस सोचा आपसे मिल लूं. तो आप उन्हें कहते हो कि भाई साहब कुछ भी कह देना, अपनी चिट्ठी में मेरा नाम मत लिखना. So this is the story of most of the doctors who treat premature ejaculation. Really. Acha, tell me something about the pelvic floor exercises, Dr. Rahul.
No, pelvic floor exercises, it's very simple, sir, but whether it really works or not, I'm not going to say, sir, because all these things started when there is no medical treatment.
Yeah, but
and second thing, I see, when you are practicing, sir, at least in premature ejaculation, now once before you start medication, you are on the upper hand. Once you start medication, then patient is on the upper hand. So now you have to give them, and if you tell them this is your lifelong problem, you can't, we can't cure your problem, then we are aggravating the suicidal tendency. So we have to give them some assurance, and giving that assurance, sometimes patient, they take it on the other way. Next month, they'll come back and say, doctor, you said it is treatable. I am taking medication since 2 months, 3 months. There is no improvement. What have you done? So there we have to be a little clever. There what we say is we ask them to do pelvic floor exercises. Pelvic floor exercises is just like they have to retract their pelvic floor muscles, like how we when we are urinating, when we want to stop urination, the type of exercise what we do. Generally, I ask them to do it for 30 seconds. 30 seconds whenever they are sitting, because this can be done in lying down position or sitting position or standing position. So even when they are traveling, sitting, waiting for something, or sitting in the office, they can do. I ask them to do it in 10 counts, 10 times, which takes around 3 to 5 minutes, and 4 to 5 times a day. But most of the patients don't do.
No, but it is very important that you give them pelvic floor exercises. They mentally are engaged, and they feel they're doing something. And in fact, what they feel is, wow, today I did everything the way the doctor had told me. And today I'm really going to do a good job. So I think pelvic floor exercise, along with the drug, just like you have said, adds to the charm of the treatment. And now, what are the sprays which you normally give to them?
So generally, I use simple lidocaine gels, because most of the sprays are expensive. What we use for in regular practice, I use Lox 2% gel. So if patient, if somebody is having sensitive glands, I ask them to apply this Lox 2% gel twice a day, morning after bath and again going to bed, for 15 to 20 days. If they do it regularly, that will temporarily desensitize the glands. Generally, this is what we do after circumcision procedure. We ask them to apply.
Yes. So you do not normally tell them to apply it before intercourse?
No, 15 minutes. That is what. See now.
Yes. So what is the protocol which you give to them while applying before intercourse?
Two things. One, if particularly in unmarried males, we don't have to worry. I ask them to apply 15 minutes before the sexual act, and I ask them to wipe it out after 2 minutes of application. Otherwise, even the partner can feel that numbness. And sometimes if it is too numb, they lose erection
Absolutely.
because it's too. So now that is important because for some people it takes around 30 seconds. For some people it may take around 90 seconds. So I ask them to apply it and then clean it after 1 to 2 minutes.
Okay. Now, another thing which I want to ask you is, how useful have you found behavioral therapy?
Behavioral therapy, definitely it works because at least they will understand what is happening.
Absolutely.
And slowly they will understand what the severity of premature ejaculation. So now we have to make them busy, as you said, even pelvic floor exercises. And every time you there is one more advantage is most of the people they don't do. Then
Yes.
the moment patient says, sir, this particular medicine is not working, then I will say whether you are doing pelvic floor exercises or not. Most of them they say, I am not doing. So you are on the upper end, sir. This is just practice point.
No, it's a very practical thing, because apart from the fact that you are treating these patients medically, you also need to treat them psychologically, counsel them, and you need to put them onto the job where they need to put in an effort. Whenever a patient comes to even me for even oligospermia, or may it be a sexual problem, till the time you give them a core to do, a work to do, they do not feel satisfied. And I think that's very important. Beautiful. Another thing which I'd like to ask you, Dr. Rahul, is that how do you explain to these people behavioral therapy? Do you have any videos which you show to them, or do you show to them on a model? How do you explain to them?
No, I have literature on laptop. I have images and literature.
Right.
I ask them to take it, and if somebody wants that literature, they can copy it from my friend list.
Okay. From your
friend
list.
list.
Friend list. Okay.
Friend list.
Great. Now the second case is there. So first case, we know that this unmarried man. Now we have a married man. Yes, please.
Sir, I think the previous case, I think we are missing one point.
Right.
So at least our doctor should know when we are using SSRIs, what dose we have to give.
Mm-hmm.
Yes.
Absolutely.
Because these drugs are available in various strengths. So generally what I do is fluoxetine. There are I either start with, if patient says if unmarried male, very minimal premature ejaculation, I start with 10 milligrams of fluoxetine on daily doses. If it is moderate, then I give 20 milligrams. Generally, I don't cross the 20 milligrams doses if he is taking on daily doses. For paroxetine, either 10 milligrams or 12.5 milligrams sustained release tablets. I generally start with this because paroxetine is known to cause sleeplessness, sometimes anxiety, and bowel disturbances are very common with paroxetine. So most of them, they come back with diarrhea, drug-induced diarrhea. And so if it is daily doses, fluoxetine maximum is 20 milligrams, paroxetine 10 to 12.5 milligrams. Depoxetine comes in single doses, 30 milligrams on demand. So I start with 30 milligrams and maximum dosage is 60 milligrams.
Okay.
We can actually combine this.
And what is the time that you normally give these drugs?
Fluoxetine I give at bedtime after dinner, but paroxetine it takes some time to act. So generally I give it in the afternoon or evening tea time. I ask them to take it in the tea time.
And depoxetine?
Depoxetine 1 to 2 hours before interval.
So this is very important. And Dr. Rahul, I think you have brought in it so beautifully, the dosage as well as the timing of the dosage. So this is something very important, very important in this particular treatment. So now case one is an unmarried boy who thinks he should get married. He has a big problem and that his problem is solved. So now we come to a married man. So Dr. Rahul, now when a wife is not happy sexually with a man and she brings this man to the clinic and says, "Zara inse poochiye inki pareshani kya hai," it creates havoc in the mind of that man. So this man has been brought. He is Mr. Vineet, 27 years old, by his wife to the clinic, and the wife says, "Dr. Rahul, Please ask this man what is his problem. And the man is quiet, he answers nothing. Now, if a man like this comes to you with his wife, what all can be the situations because of which this is happening?
Sir, this is a very difficult situation for any male. Any male, even a normal male, if there is a failure and if wife, even if he's normal but wife is complaining, then it's a difficult situation for male. It's like an examination. Every act of intercourse, instead of pleasure, it becomes like an exam. Always, like a student going for an exam without proper preparation, that always that stress will be there. So now we have to actually say whether it is really a premature ejaculation or it's because of fear of performance. We call it as performance anxiety, which is causing this. Or sometimes these people, they'll have a combination of erectile dysfunction and performance anxiety. So there we have to see whether it is only erectile dysfunction or only premature ejaculation, or whether it's only a psychological fear. And it's always difficult. This is the difficult set of patients. So what happens, even after giving medication, this man always, he will find causes to avoid intercourse because his confidence will be on the lower side.
Correct. I mean, it's so beautifully explained that a boy who's not prepared for the exam will tell him ki pet mein dard ho raha hai, aaj imtihan nahi dena. This is the story which happens. So very, very beautifully says. Now, just like, is there that whether it's ED, whether it's performance anxiety, whether he has it with masturbation, and genital examination needs to be done. So now when we have done this is what we have found. We have found that wife is not happy. Genital examination shows phimosis and a sensitive glands. Testosterone is low. Other hormones are normal. Now, what are you going to do in a patient like this, Dr. Rahul?
So here, sir, once there is phimosis and sensitive glands, so two things. Anyway, they need circumcision. At any point, they need circumcision because every time they try to have intercourse because of his phimosis, he is going to fail. So, and every time he fails, that is going to take down his confidence. So now, in these cases, what I do is, if he is not scared of surgery, I will tell them that there is a procedure and we'll do the procedure. But what we have seen is most of the females, if a husband is undergoing a procedure for this purpose, their perspective will change. They think, at least my husband is doing something for this problem. But
true,
if he is not doing anything, if he is avoiding intercourse for a long term, and if he is not taking medications, then anyway, it is going to create a negative impact in wife. This will lead to marital conflicts. So I will explain all these things to the male. I will ask them to undergo circumcision, and circumcision will help in two things here. One, it is anyway going to desensitize the gland, and it is going to help him in having proper intercourse.
Okay, great. And the second thing I want to ask you is testosterone is low. Will you do anything about it?
No, testosterone, we have to correct the testosterone. But since already I think we know that testosterone should not be, since he's a recently married male, and testosterone should not be with testosterone injections, we have to see why testosterone is on the lower side. So whether testosterone is on the lower side because of low FSH, LH, or lack of sleep, or his lifestyle, first thing is he has to change his lifestyle. But if you say you have to change his lifestyle, you have to regularly exercise, and generally that is going to take a lot of time. We have to give some pharmacological treatment. One can be clomiphene citrate, or other it can be HCG injections, gonadotropins. We have to increase their heart. And once you correct the heart along with the treatments, generally what I do is I counsel them for circumcision, and during the recovery phase I correct the heart, because he has to anyway, after circumcision he has to wait for at least 3 to 4 weeks before he tries intercourse.
Absolutely, absolutely. Beautiful. So, Dr. Rahul, as far as this patient is concerned, now his hormone is corrected and he's able to perform with his wife. He has undergone surgery. So, the wife is happy that my husband has undergone surgery for something which I needed. And finally, they are on to a happy married life to have children. But the third case is 48 years old. And this gentleman was
Sir,
fine.
can I add one point, sir?
Yes, please.
Yes, sir. Sir, as we thought this is a difficult case scenario, by just giving SSRIs alone, this man is not going to perform. Because
Correct.
he is already in anxiety, wife is demanding. So here only SSRIs will not work. Though his erections are normal, we have to support his erections by giving a PDE5 inhibitor.
So what PDE5 and what dose are you going to give to him?
Generally, I start, sir. I give them 5 milligrams of tadalafil on the daily doses, along with either fluoxetine 20 milligrams or paroxetine 10 milligrams on a daily doses. And on the day of first intercourse, after once he recovers from the circumcision wound, and when he's trying on the day, we have to either give him 20 milligrams of tadalafil or 100 milligrams of sildenafil, along with depoxetine 30 milligrams.
Right. But but yes, you would only start this after the circumcision has healed.
Yes, yes.
Great.
No, during healing phase,
tadalafil, even at the time when you've done a circumcision, you will not ask him to stop taking tadalafil till the time his circumcision has healed.
No,
otherwise
sir,
he'll have
yes. If there is ED, then anyway he is not going to get hard erections with 5 milligrams.
But then normally after a circumcision you would like to avoid a tadalafil or a
at least
sildenafil.
1 week. After 1 week, they won't have pain.
Yeah, after 1 week start. Great. So now we come on to the third case. Now this third case is 48 years old. He complains of premature ejaculation for 3 years and occasional ED. Now, if you have a man like this who's 48 years old, what would you think this man has? And how will you treat him?
Yes, obviously, it is a secondary premature ejaculation. That means we call it as acquired premature ejaculation. There should be some cause for this premature ejaculation. Either erectile dysfunction itself, or hormonal imbalance, or even secondary recurrent balanoposthitis can cause premature ejaculation, or even prostatitis or seminal vasculitis can cause premature ejaculation. Because in this case, he is around 48. First thing we have to see is hormonal imbalance and erectile dysfunction.
Okay. Now, if we ask for the sexual frequency of this man, why would we ask him for the sexual frequency?
Sexual frequency is again, sir. So now sexual frequency is to decide the treatment. Now, if he says, doctor, I want intercourse once in 15 days, then we don't have to put him on daily doses. We can just put him on demand combination of tadalafil and depoxetine, which is easy for us. Only thing, if he says I want daily intercourse, then we have to look for a permanent treatment.
So we have seen all the causes, and now we'd like to ask you, what is the treatment for secondary premature ejaculation?
Secondary premature ejaculation, it depends on the cause. Depends on the cause. I think whether it is prostatitis or seminal vasculitis, we have to treat the infection first and then start SSRIs. And if they are initially responding with depoxetine, they can use depoxetine on demand till it works.
Great.
And if it is recurrent balanoposthitis, then probably again we have to ask them to get circumcision done. This is common in diabetic people. Once they get balanoposthitis, it is going to recur again. And if there is erectile dysfunction, then we have to treat the erectile dysfunction first. Most of the patients, we treat, if we treat erectile dysfunction, they'll be all right. So then we don't have to give actually premature ejaculation.
So now we have had 3 patients, unmarried. Second is a married man whose wife has got him after seeing a lot of movies and saying this man can't perform. Please make him okay. And the third man is a 48-year-old man who has been having a great life till 3 years back. And now he says, I'm in a soup. Please help me. So Dr. Rahul has helped all these 3 patients. But now we're going to have a fourth case. And this fourth case is very interesting because this fourth patient is 33 years old, ED since 3 years, and he's been going to all the quacks all around for ED for 3 years. And now he feels he has premature ejaculation for the last 6 months. So the man is upset. 33-year-old married man who feels his life was on the run. And suddenly 3 साल पहले ब्रेक लग गए और अब गाड़ी ऐसी चल रही है कि बस 2 मिनट में इंजन बंद हो जाता है. Now, how do you manage a man like this?
So this is a difficult situation for him, sir, because he's only 33 years. And now these kind of patients probably, if you see, erectile dysfunction has started first and later premature ejaculation. So this premature ejaculation can be simple psychological cause because of his secondary to his erectile dysfunction. So now we have to correct his erectile dysfunction. Then he may not like to depend on temporary medications. These kind of patients, they want some sort of permanent treatment. So now we have to find out the root cause for his erectile dysfunction. First, treat the erectile dysfunction. If erectile dysfunction is normal, if it is psychological, then you don't need any premature ejaculation.
Now, yes, please carry on.
If he says, in spite of treating erectile dysfunction, generally what we can do is initial days we can give him low dose SSRIs, and after that we can stop SSRIs. If he is all right, then we don't have to continue medication.
Now that will be a whole different topic, talking of ED, of how to treat ED. And since today we would just like to concentrate on premature ejaculation. In fact, Dr. Neeraj Yadav is very, I love the fact that now he's bringing on to consensus. I love Apurva because of the crazy energy he has. I wish these sexually dysfunctional patients had the energy which Apurva had. They will not need any medication. I can assure you that. Now, this is the 5th case, and this is a very interesting case. The 5th case is a 34-year-old male with severe PE, premature ejaculation, complains of chronic lower urinary tract symptoms, post-ejaculatory pain, penile and perineal, has tried all SSRIs, no improvement. How will you manage him?
Sir, based on his complaint of severe premature ejaculation with the chronic lower urinary tract symptoms, that means most of these patients will have frequency, urgency, which are common symptoms, and post-ejaculatory pain. Again, all these are signs of chronic prostatitis. So now definitely that is why he is not responding with SSRI. So now we have to find out what is causing all this. Basically, what is the root cause for prostatitis? Sometimes it can be viral, sometimes it can be bacterial, sometimes it can be a non-bacterial prostatitis. So we have to treat the prostatitis first. Then, if after treating prostatitis, then we have to restart SSRIs. Most of them respond.
Okay.
But we have to counsel them, sir, because treating prostatitis is going to take a lot of time, at least 2 to 4 months.
So if you have diagnosed this person with prostatitis and you are treating prostatitis, normally how much time would prostatitis take to get treated?
2 to 6 months, at least, to decrease their symptoms.
Okay, to decrease their symptoms. So during that time when prostatitis is being treated, what is it normally that you're going to tell these patients?
Because already they have tried all the possible medication. I
Right.
just ask them to take high dose sildenafil and high dose depoxitin to try. If they succeed, probably they use it. I ask them not to use it too often. I ask them to try once in 10 days or once in 2 weeks till their prostatitis, because most of the times they might have tried all the possible medications. And I ask them to ejaculate frequently, because these prostatitis patients, whether they are having intercourse or not, when they are on medications, they have to ejaculate frequently. Otherwise, it's very difficult to treat prostatitis.
Are you talking of acute prostatitis or chronic prostatitis?
Even chronic, they get relief with frequent ejaculation.
But acute can get flared up.
No, acute. See, acute generally you can't. Acute, actually they'll have pain. But after once you start anti-inflammatory and antibiotic, probably after 1 week, during initial antibiotic phase, probably they don't need. But after that, they will be all right.
Right. So,
can you just ask to throw more light on how to manage prostatitis?
Okay, now, right. How to manage prostatitis? This is what a lot of people will like to know.
Yes. See, prostatitis, first thing is we'll see what is causing their prostatitis. So sometimes this is common in young unmarried males, because sometimes some people generally they don't masturbate at all because of the bigs. Even those people can have prostatitis because of very occasional ejaculation. And people with STDs, sexually transmitted diseases, they can have prostatitis. That can be viral, that can be because of chlamydia, that can be because of herpes simplex. And commonest cause what I have seen in general population is bowel disturbance. Bowel disturbance, like even patients with chronic constipation, fissures, fistulas, they will have chronic prostatitis. So now we have to identify the root cause. Generally, I do a semen culture test. Semen culture, if it says Enterococcus fecalis is the regular organism, then the organism is from the bowel. It's from the rectum. So now we have to treat it for give antibiotics for that particular organism, and I ask them to get their constipation treated from a gastroenterologist. But if it is because of STD, sexually transmitted disease, then I ask them to consult a dermatologist, get his STD treated. And because it's prostatitis is a multifactorial issue, so now we have to, only way we can treat it is long-term low-dose antibiotics and anti-inflammatory drugs.
So what
Sometimes
is the
antibiotics? Antibiotic, it depends on the culture. If it is Enterococcus fecalis, generally ampicillin is a wonderful drug for Enterococcus fecalis. I give it for 3 weeks, 3 to 4 weeks, 500 mg twice daily, along with some anti-inflammatory chymotrypsin based combination. And if it is E. coli or Klebsiella organism, if organism is Klebsiella or E. coli, then ciprofloxacin works very well. But I give them very low dose ciprofloxacin to start with, because they have to take it for at least 3 to 4 weeks. And doxycycline is also wonderful drugs for chlamydia. People with chlamydia and unknown STDs, azithromycin and doxycycline are I think they are favorite drugs for dermatologists.
Correct. In fact, just like Dr. Rahul Reddy has said, there are two things for us to understand: that if we want to avoid male accessory gland infections, if we need to treat prostatitis, we need to give antibiotics for a long time. Even in a urinary tract infection, if a man has a UTI and you give him antibiotics for 3 days, and after 3 days his burning goes and he stops the antibiotics, the chances is that he is going to have a male accessory gland infection, because these bacteria are going to go get settled there. One. And the second thing, just like Dr. Rahul Reddy said, initially for acute prostatitis, you may need to give a higher dose so that it may cross the barrier and it may be treated. But ultimately, for a chronic prostatitis, once it is there, it needs to be given for a longer time. Now, we have a fifth case. Now, I would like to ask you another fifth case. Is there any surgical role of management for PE?
Yes. Sanjay, so this is what I said. If patient is having either phimosis or tight frenulum, then we have to do circumcision or frenuloplasty. And some patients where nothing is working, like in case 4, where we have seen a patient is not responding to any drugs, there generally we can do selective denervation of penile nerves. So it's a Korean technique. I think one Korean clinic has started this. It's called switch technique. It's working well because I tried in around 11 cases till now. 8 of them are happy. In
So
3,
what do you
even
do? What do you do in this switch technique?
basically we have to give circumcoronal incision, like how we do for circumcision. We have to identify the penile nerves, dorsal penile nerves, and we have to cut them.
Okay, so you normally do it at the base of the penis?
No. 1 centimeter from the glands.
1
1 to 2
centimeter from the glands.
The same
Okay.
like circumcision incision.
Now, case number 6, 26-year-old male, severe PME, non-consummation of marriage, masturbating since 14 years, sometimes 3 to 4 times a day, comes to Dr. Rahul Reddy and says, बचपन में बहुत गलती कर दी और अब बेकार हो गया हूँ, शादी नहीं हो रही, बीवी डिवोर्स का केस होने वाला है, सुना है दहेज का केस भी पड़ जाएगा. What to do? Now, Dr. Rahul, what are you going to do in this matter?
This is again common scenarios. So people who start masturbating, either this can be habitual or this can be lifelong premature ejaculation. It is little difficult to differentiate whether this is a lifelong or habitual premature ejaculation. So now these people, they need a lot of counseling. I think we have to talk to the partner also, because even partners should understand that this is going to take some time, because unless we give assurance to the partner, his marriage is not going to sustain. So this will end up with divorce. So now we have to counsel the couple, and then we have to start the treatment for the male. Then these people, they need very long long-term SSRIs.
Dr.
SSRIs.
Rahul,
Yes.
yeah. Dr. Rahul, can you tell us, with this case itself, something about masturbation, the myths of masturbations? How do you need to counsel a patient who's masturbating? Because this is very important. I mean, 90% of the problem lies with the masturbation which he has done in his mind. And he understands a lot of things have gone wrong with him. What do you normally do? How do you counsel them? What are the myths and how they need to be solved?
First thing is we have to explain them masturbation is not wrong. So but though it's difficult for these people to take, because they don't believe you. Even if you say masturbation is normal, they don't believe, because it's there, it's in their brain that they have committed some sin since so many years. But it takes some time for them to understand. Generally, what I ask them to do is, I ask them to talk to their brothers, cousins, friends. So I ask them to find out whether they masturbate or not, because once they say they are also masturbating but they are normal, then they think masturbation is not a sin. So we have to spend some time with these people. We have to ask them to see the literature, because sometimes you see these people, sir, if you see TV ads, which are scrolling ads in the news channels, these quacks, they keep on advertising that we treat side effects of long-term masturbation. And
Correct.
Even quacks, you see a lot of posters, they say we treat side effects of long-term masturbation, because they get confused. They think that these things will reinforce their myth. So first thing we have to tell them, masturbation is not a sin. It is normal. Most of the males, they do masturbate. They masturbate, and there is no harm with masturbation. And only thing is overdoing. I generally counsel them that over masturbating is a problem. If you are doing 3 times, 4 times in a day, that is not normal. If you can masturbate 3 times, 4 times in a week, that is normal. Slowly we have to tell them masturbation is normal, but frequency is not correct.
True. Dr. Apurva, can you ask the next question, please?
Sir, one situation, one treatment, sir. These patients, generally I do one thing, because already there is non-consummation, severe premature ejaculation. So these people will respond with trimix injection, trimix or bimix injection. First time I ask them to take the injection, and they'll have prolonged erection. So they can have at least intercourse once, because it's a case of non-consummation. Even after ejaculations, because of the trimix injection, they will have erection for some more time. So they can at least penetrate, and they can consummate their marriage.
Yeah, great. It's a great insight. So those patients who have non-consummation of marriage because of the male particularly, do you normally give these patients trimix so that they may at least consummate the marriage?
If they are not they haven't tried other PDE5 inhibitors, first we will give PDE5 inhibitors, a combination of PDE5 inhibitors with high dose depoxytin. But if they are not responding, generally I don't waste time here. I give them only 4 to 8 tablets. I ask them to try 4 or 5 times and come back. If they are not able to consummate, then I take them for trimix injection.
And you make sure that the woman has been examined and counseled from the point of view she doesn't have vaginismus, or she doesn't have a female sexual disorder.
Yeah,
great.
Good point.
So now, Dr. Apurva.
Yeah, after this, such a wonderful questions, because this is what we are seeing in our clinical practice is just I think it's a tip of icebergs. And people are actually not come up with these type of things, and majority 90% of them are treated by some cracks. So there's a lot of myths regarding it, and definitely what Sunil sir has said, yes, premature the masturbation, really it's one of the mysterious things which people have. So coming to the next question, this is a 38-year-old male, and it has an occasional and situational premature ejaculation only with wife and no with the girlfriend. Sir, how will you manage this type of cases? So I have, and it is not very unfrequent, because many time patients came and they said ki sir abhi to ye garbad hai, but I had a previous relationship with a lot of girls and I was like a macho man for them. So what to do, how to convince is this type of cases? Yeah.
So this is a typical situation, doctor. Generally, we see very common. See, what happens is when wife is demanding, or sometimes if wife questions his performance, then most of these people, they get detached from the wife, because whenever they see their wife, generally they avoid intercourse, or that because of the performance anxiety, even if they try to have intercourse once in a while, they will end up with premature ejaculation. So now we have to treat them. Initially, we have to give them some confidence, because since he's performing well with his other partner, so it's a purely psychological thing. So now to get rid of this issue, initially we give them on-demand medications. Whenever he's going to his wife, he has to take a combination pill of tadalafil and depoxytin, and slowly once there is successful intercourse for a couple of times, slowly you will get his confidence. Then I ask them to try without medication. After 5 to 6 times with medication, then once or twice without medication. Then if he's okay without medication also is able to perform, then it's okay. Otherwise, I ask them to continue for a little long time.
Okay.
But they have to be on medication for at least for first 4 to 8 times of intercourse with wife.
Okay. Sir, I just wanted to ask one thing, because in this particular type of cases, do counseling has some role?
Yes,
Like
definitely,
without medicines?
definitely.
And sir, whatever the patient, this type of patients, when these are coming to us, they always insisted us, sir, please don't give us the medicines. Medicines have a lot of side effects. Can you
Yes.
give some herbal medicine, something like that, like Himalaya or something? So
They
it
need
doesn't
placebo
have,
treatment.
and it, we can take 10 or 15 days and it will cure like for lifetime. So
Yes, yes, definitely, doctor. These drugs, they act like placebo because for him, anyway, there is no major issue. He wants some confidence. So even if you give him some herbal medications, he's going to perform.
इनफैक्ट चांदनी रात को अगर आप इन्हें चांद दिखवा के चटनी चटवाएंगे तो बहुत खुश होंगे क्योंकि चांद के लिए इंतजार करेंगे. So somehow there is some problem with my video, it has gone. So anyway, so now the next case, Dr. Apurva, which is going to ask you is,
yes. Sir, again, this is a 30-year-old male with a complaint of premature ejaculation since 4 years. Started after unprotected exposure with a sex worker. So what do you think? It is a psychological, it's a STD or something else, or how to manage this?
So in 80% of cases, it is because of STD, sexually transmitted disease. As I said, most of these patients will have either urethritis or seminal vasculitis or cystitis or prostatitis. And 20% because of that fear of that STD itself can cause erectile dysfunction or premature ejaculation. I have seen so many patients, they avoid intercourse with their wife for years together because of the fear of transmitting.
right. So now
I refer these patients to an STD specialist first or dermatologist. First, I'll ask them to get them evaluated properly, and if there is any STD, they will treat. And I ask them to come back for premature ejaculation treatment.
right.
Sir, I just want to ask you a few questions which commonly I get in our OPD regarding that. First, there are some condoms companies, they are actually name that using then and you will last for more. So is there any scientific basis or they are just as an advertisement?
No, they temporarily numb. It's like using local anesthetic gel. Definitely, there is some advantage. But because if somebody is having phimosis or somebody is having sensitive glands, once you use a condom, that is going to act there on locally for some time. They work, really, they work out.
Sir, again, we are getting a lot of questions like that. Anything which naturally increase the time, like any food, any exercise, or anything. Akroot khale, pan khale. Hyderabad ke pan is very famous. So something like that, which actually these have some basic scientific evidence, or these are all myths.
Basically, if it is psychological, anything can work out. As I said, placebo treatment, as you asked, anything, even if you give one vitamin tablet and if they say it works, definitely it works, because for psychological people, they just want confidence. And for people, other people, like what Dr. Sunil sir said, even pelvic floor exercises and stop squeeze technique, that works in some people. But it needs lot of patience, because every time they masturbate, they have to squeeze it. It's not a one-day procedure. It takes at least 6 to 12 weeks. They have to regularly do these exercises. They will be all right.
And sir, about the pelvic floor exercises, what you have told that we have to hold the urine at the mid of the urine for 3 seconds, 30 seconds. Yes. So is the Kegel type of exercise which we are offering in a case of females, this does has any role in case of male in case of premature ejaculation?
Which one?
The Kegel's exercise?
Yes, yes, definitely, because it is going to strengthen pelvic floor.
Okay. Secondly, sir, in the market, we are seeing a lot of products like, some natural herbs like Chinese herb, Jinjikova, and something like that. So is it evidence based or it was just eyewash?
No, see, definitely, doctor, since so many centuries, our natural system, they are treating premature ejaculation. So even when all these medications were not available, our ancient people, they used to treat hypercum perforatum. There's so many herbs which actually works on premature ejaculation. Nowadays, there are so many companies which are manufacturing a combination product for premature ejaculation. Tribulus works in some patients, hypercum perforatum works in some patients. They actually, but only thing is you have to do them in combination with your SSRIs.
Okay.
What you advantage with that is you can actually decrease the side effect of SSRIs because most of the people are worried about side effects. Even now, there is a new study says even paroxetine daily doses have suicidal tendency, can cause suicidal tendency.
Correct.
Now, instead of giving high doses, you can give a combination. You give very low doses of fluoxetine or paroxetine along with these herbal medications. There is nothing wrong in trying.
In
And
fact,
doctor, already, since how long they can take this medication? Suppose we put patient on SSRI, how long they get maximum they can take?
Maximum 2 months.
Okay. Not
Because
more than 2 months.
if they are generally after giving SSRIs for more than 2 months, that itself can cause erectile dysfunction. All these SSRIs can cause erectile dysfunction. They can decrease the libido. So long-term usage is also not preferable.
so what will you do after 2 months?
After 2 months, either I shift to on-demand medication, or I will give a gap, ask them to continue on-demand medication. After 2 months, then I ask them to take. Because most of the patients, they say, sir, when I take the long-term medication, a daily dose medication, I'm confident whenever I perform, I don't have to depend on, I don't have to look for timing. Because they don't, if they are on daily doses, sir, anytime they can participate in intercourse. But if they are on on-demand medication, they have to, every time they have to time their intercourse. They have to pre-plan the intercourse, timing, time to take medication. Everything has to be planned. Because most of the people, they may not like it. So I ask them to take gap of 2 months. Again, after 2 months, I'll restart daily dose.
But
Acha, doctor,
especially in newly married couple, it will be difficult to stop after 2 months.
Sir?
Especially in newly married couple, it will be
Yes.
difficult to stop after 2 months. So in this scenario, what will you do?
See, in the on-demand medications, depoxetine. So depoxetine is an on-demand medication. So
Right.
in that period, I ask them to take depoxetine. And most of the people with psychological premature ejaculation or performance anxiety related premature ejaculation, after marriage, if they have a regular partner, what we have noticed is that after marriage, if you give these medications for 2 months, they get their confidence. Even if you stop these medications, they won't have premature ejaculation. But if they change the partner, then definitely again with the new partner, they will have premature ejaculation because of the performance anxiety. So generally, I don't give these medications, daily dose medications, when they don't have a partner. I ask them to come back just before marriage, and then I do this medication.
Sir, I have seen that in patients, they develop actually the resistant with the sildenafil and tadalafil, where they are using it for long time. Is it the psychological, or is there some basic, basic mechanism behind that?
Basic mechanism is, doctor, see, now there is an underlying cause for erectile dysfunction. Either it can be vascular damage in the penis, or vascular stiffness, or endothelial dysfunction, or hormonal imbalance, or low testosterone. So now what happens, if initially there is low testosterone, we correct the testosterone, we leave it, and we ask them to take tadalafil. After a month or 2 or 3 months, slowly their testosterone levels again, they start falling down. When it falls down, then this 5 mg what you are giving may not work. Or if a patient is diabetic or hypertensive, if he is not maintaining their hypertension or diabetes, then this same dosage may not work for long, because the vascular damage, it's always progressive. So you have to continuously treat the underlying cause and then continue this tadalafil or sildenafil.
Dr. Rahul,
Yes,
now let's have a few questions on the drugs, because Dr.
Yes.
Apurva, don't you think it will be very important for ask a few questions on the
Definitely,
drugs?
sir, definitely, because these are the main treatment of premature ejaculation. So we have to, and there's
In
a lot
fact-
of confusion regarding
in
the
fact,
doses and all.
Yeah, in fact, Dr. Neeraj himself, at the time when we were discussing this program, was there of that we should talk a lot about the drugs so that they can be used correctly. So now, first of all, let's go to depoxitin. Now, Dr. Reddy, how would you use a depoxitin? In what dose? What has been your experience with depoxitin?
So depoxitin, I start with 30 milligrams. I rarely use 60 milligrams, because even with 30 milligrams, majority of people, they complain of side effects.
Okay.
So common side effect what I have seen is dizziness, decreased sexual desire, and diarrhea.
Okay.
If
So-
they are tolerating well, then probably I can increase it up to 60 milligrams if they are not happy with their ejaculation time.
Now, do you combine this drug with sildenafil? And if you combine it with this sildenafil, when and in which patients, why and how?
Generally, I don't combine with sildenafil, sir, because if you see, even in the market, combination drugs, always all those sildenafil and depoxitin combination drugs, either they are out of market now or they stopped production. Only I think Jadus has stopped, but again they had a problem with the dosage combination. So I don't use a combination drug for sildenafil and depoxitin. I ask them to, if at all there is a need, I ask them to take both the tablets separately.
Right.
Because
Now-
formulation, somehow there is some problem, always some problem.
No. What I'm asking you is, which are the patients which you will give along with depoxitin, sildenafil, or tadalafil? Which set of patients will you give this together?
Patients with erectile dysfunction. Erectile dysfunction are patients with non-consummation, or patients with performance anxiety where wife is demanding. So there I have to give PDE5 inhibitor, otherwise he is not going to perform.
Okay. Now, which are the patients you will choose fluoxetine for, and which are the patients you will choose paroxetine for?
So, Sunil, just I want to ask, if you are putting patient, Dr. Rahul, if you are putting patient on depoxitin, is there any, if you can put safely on, if suppose patient is on cardiac problem or having hypertension, can you put on depoxitin or?
Depoxitin is safe. Depoxitin is safe. Only
It's a
thing
very
is you have to look for PDE5 inhibitors. When you are giving sildenafil or tadalafil, you have to go, think of other drugs, but these drugs are safe.
Very safe. Correct. So now, which are the patients in whom you would give fluoxetine, and which patients will you give paroxetine to?
So generally, what I feel is paroxetine is more potent drug for premature ejaculation. So people with very mild premature ejaculation or psychological issues, I start with fluoxetine because there are very less side effects. Paroxetine in patients with severe premature ejaculation, instead of wasting time with fluoxetine, I directly start paroxetine.
Okay. So, which are the patients in whom you would give tramadol, and what has been your experience with
Tramadol,
tramadol?
generally, I don't give tramadol. Because there is literature that it works, but I haven't tried.
Okay. Now, lidocaine, you have told us that this is the way you would try it, and I think Dr. Apurva and I are, now that we are at the end of the presentation, so I think at this time we could stop the slide share. My camera unfortunately has gone. There is some issue with it, I don't know. So at least the voice is on. And Dr. Neeraj, please.
Sir, you have to unmute yourself, Neeraj sir.
Dr. Rahul, we would like to know any interesting case in this, other cases which presented today. Any other interesting case in which you encountered? You would like to know about that.
No, I think we have
Covered
covered most of the
almost
cases.
everything. Correct. Very true, sir. Sir, is there any, Rahul sir, is there any indication of like if in this particular group we should use depoxetine, and in this particular group we are using daily dose fluoxetine and paroxetine?
You can actually you can actually combine those drugs also.
Okay.
It's like, see, people with severe premature ejaculation who wants permanent treatment in the sense they want some solution. There you can actually give daily doses of fluoxetine or paroxetine. Along with that, you can actually give on-demand depoxetine. It works.
Suppose that in that particular day, patient is already taken paroxetine in the evening. So is that can be taken depoxetine in the night?
Yes.
8 o'clock?
Yes, you can take.
Okay. That is the most. That is it.
But severe cases, doctor, severe premature ejaculation, these paroxetine or fluoxetine, they may not work immediately. They take some time. So in the beginning, you can actually give on-demand doses along with that. And once they start responding to fluoxetine or paroxetine, then we can stop on-demand depoxetine. So you can ask them to continue on.
Sir, last one questions. Every time the people are coming and they said that garlic has some effect, some certain kind of pulses have some effect on that, or akhroat is had some effect. Even once a person told me that I just forget that particular fruit. That particular fruit is resemble like the scrotum. So if you are taking that particular fruit, your timing and everything will increase. So is there something like that? Is there any food habit, anything which can increase the time as well as improve this premature ejaculation?
Specifically, I don't know any particular kind of food. Sometimes it is a myth. Even I have seen a lot of African patients. They take only honey, and they think that by taking honey they get very good erection. Maybe a medication, but don't know. Always say, even I have seen a 65-year, 70-year-old male coming to say, doctor, I don't take any drugs. Whenever I want to perform, I take honey. Maybe that is psychological, or maybe they are helping.
Sir, I has a very interesting case, and that wife is actually asked that if somebody has told her husband that garlic has a wonderful result. So every night he is taking that raw garlic, and it was so smelly that after taking, she is unable to come in front of him. So this type of myths are definitely happening.
Yeah. Dr. Rahul, can you throw some light on the sunset focus therapy?
So I am not trained in that, sir, because I think most of the psychosexual therapy, I don't do psychosexual therapy. I send them to people who does it, because most of the psychiatrists, they do that.
Can you throw some light on sunset focus therapy?
See, I'll be very honest with you.
Yeah.
We as clinicians, they say so much of time which is taken on these senses focused therapies that we really do not have the time, the inclination, or I would really tell you very honestly, it's a whole new story altogether of training for all of us. So there are very few even psychologists who trained for this. I'll be very honest with you. Even those people who giving this therapy, like I know of 2 people who give this therapy and they're not trained for it. So I have a feeling that there should be a system in which all of us should somehow get in the next series which you are creating, in the next series after this, somebody who can train all of us in this therapy. I think that would be great.
So I think there is no more question or no more confusion. If everything is clear, crystal clear. Apurva, are
I
you there?
think,
Yeah. Yes, Sunil.
yeah, I personally feel, my camera, I don't know what's the problem. I think I put in a new antivirus, and it was again and again showing me the camera. Do you want the webcam to be scanned by the antivirus?
No, your
And
camera needs
eh,
depot
eh,
setting to put
no, and I
whenever
said,
you your
no.
camera need a depot setting. It
Yes,
is
yes. And I
it
said
has not
no.
it has not
And I said no. And so the virus has got into the camera, not the antivirus. So I just cannot leave, but that's the way it's happened. But Dr. Neeraj, I must compliment number one, you for the amazing series which you have started. I mean, the first series was the masterclass series.
yes.
Now it's a consensus series of cases. And Rahul, you are amazing. The way you simplify a complex problem is so beautiful. In fact, you really give chocolates to people out of something so difficult. So I think that's beautiful. Apurva, I don't know, his camera is off. There is no virus.
Apurva, are you there?
His mic is off. He may have just felt at this time that he wants another cup of tea. But anyway, I must compliment. There he is. So Apurva, I was
Yes,
just
sir.
saying that what an amazing program this is. And I'll request you, Dr. Neeraj, that the next set of programs after this is over should be on psychosexual therapy. And there should be a
Exactly.
training program for all of us where somebody teaches us.
Exactly.
I think that should
because
be.
General sir, every time we are talking about behavioral therapy, cognitive therapy, this therapy, those therapy, family therapy, couple therapy, individual therapy, but actually there is a lot of confusion even in the therapist that what particular is the difference between those therapies. So you are very correctly said, sir, and
Yeah.
definitely
Yes,
we
yes, at
And
least
I
we
think-
should know what is this therapy all about. Because
all about.
If there can be a good some trainer whom you could
Yes.
find, which you will, because now anywhere where sexual therapy is there, so Dr. Neeraj is there. So I ultimately feel that any therapy in the country, and you're doing a great job, because I personally feel, and I say this on this particular podium, this is the most unexplored problem. And I was hearing the CEO of Coca-Cola speak once. He said that on this world, 2/3 of the world is covered by the sea and the rest by Coca-Cola. And what I personally, but what I feel is that in this world, the biggest dysfunction which could ever happen in human beings, where 40% of the population of this world is affected, is sexual dysfunction. And nobody wants to talk about it. Nobody wants to even discuss about it. But Dr. Neeraj has taken the phenomenal step of creating a sexual committee, which, well, actually was, I would feel, always parked in the garage, into something which has come on the best highway into the Foxy system. So कभी-कभी ऐसा होता है, लोग सोचते हैं चलो जी फॉक्सी की कोई तो कमिटी मिली, चलो सेक्सुअल कमिटी मिली, चलो कमिटी मिली. यहाँ पर इन्होंने सेक्सुअल कमिटी को टॉप कमिटी बना दिया. तो ये बड़ी तारीफ की चीज है. एंड डॉक्टर पूर्वा, थैंक यू वेरी मच.
इसमें सुनील सर आपका भी बहुत बड़ा हाथ है सर, हाथ पैर सब कुछ है.
अरे मेरे को तो ना जहां खड़ा कर दो वहां बोलने लगता हूँ, क्या करूं, मेरी तो कुछ कहानी ऐसी है.
Sir, before we end, right, Rohit, do you have any live questions?
Yes, sir.
Do you have any live questions?
Yeah, I will check, sir.
Just check it.
पता है, इसमें कोई सवाल भी नहीं पूछता. सवाल इसलिए नहीं पूछता क्योंकि नाम साथ में ना आ जाए. मैं सच कह रहा हूं आपको. मैं मतलब अगर आप इससे कह दो ना कि आप बिना नाम के सवाल डाल सकते हो तो चलेगा, पर कोई सवाल नहीं पूछता. पेशेंट भी आके ना सबसे पहले कहता है मेरे पड़ोसी को ये प्रॉब्लम है, डॉक्टर साहब वो तो आ नहीं रहा, मुझे बताइए क्या करना है.
सर एकदम बिल्कुल सही. जैसे सर वो मिर्जापुर की मूवी में आया था ना, इफ यू, वो जो उसका जो मेन एक्टर रहता है, मतलब मेन विलन रहता है, he has this problem, he asks कि my driver has this problem.
करेक्ट ये तो बड़ी ये बड़ी
There
सुंदर
is no
चीज है।
question.
Okay.
देखिए मैंने बताया था आपको, मैंने आपसे कहा था कि जो भी सवाल है सब पूछ लो, जो सबको जवाब मालूम चल जाए फॉर देयर पेशेंट्स। And I think it's been a beautiful program. Dr. Neeraj, when are you arranging the program for ED?
After 2 months.
After 2 months. Great.
Yeah.
So I think that should be another great program. And thank you very much. And I would
For
thank the
that, we
audience.
end, there is a vote of thanks by Dr. Apurva.
Yeah, definitely. So thank you so much to everyone. What a wonderful program is this. We started and we take this such a important and such a difficult topic in such a easy way and discuss each A to Z of this particular topic and how to deal with that. At the outset, first of all, I like to thank our Foxy President, Dr. Shanta Kumari ma'am, our Secretary General, Dr. Madhuri Patel ma'am, our Vice President in charge, Dr. Vipin Pandit sir, and Chairperson, the person behind all these programs, and Dr. Neeraj Jadhav sir, the today's chief guest, very own Dr. Pankaj Desai sir, our guest of honor, Dr. Kavita Vapat ma'am, and our wonderful and energetic speaker and faculty today, the Rahul Reddy sir, my senior, my co-moderator, and what to say, our Sunil Jindal sir, and to all the viewers to make and this so important and to make this webinar such a huge huge success. And I also want to congratulate the ICOG chairperson Dr. Uday Thanewala sir and the secretary Dr. Ashok Kumar sir for give us one ICOG credit point. And thank you last but not least the support team, the entire pharma, to giving us this platform and organize this wonderful webinar. Thank you so much, and stay connected. We will bring up some more important and very interesting topic with some wonderful speakers like Dr. Rahul Reddy sir. Thank you so much.
Apurva will not say, but I will say that Apurva, thank you, Apurva.
Thank you, sir.
Thank you very much.
Thank you.
Bye-bye.
Thank you so much.
Bye.